Everyone. We were talking about vision in the earlier instruction course. And if you have great vision, you need to look at some great faces. So this presentation and this instruction course will be about facial aesthetics. We are talking about a video-assisted skill transfer course on botulinum toxin, fillers, and threads, and many other devices for looking good. It's one of the upcoming specialities or subspecialties in oculofacial plastic surgery as well as in ophthalmology. And my name is Debraj Shome. For those who don't know me, I'm a facial plastic surgeon. I'm based out of Mumbai with practices in multiple cities. And we'll start off first with cadaver dissection. We've been running this course for the last 9 years. Unfortunately, Shilpa Taneja Mittal, who's been a colleague of ours, as well as a student of mine, a fellow of mine, has not been able to make it because of being unwell. So let's hear her on video and on Zoom, and then let's start off with this. Thank you once again for being here.
Hello everyone. So in next 12 minutes, we are going to learn facial anatomy through cadaveric dissection videos. Why is it important to learn anatomy? Anatomy of any region is the most basic, yet the most important part to know before any procedure for safe and efficacious injections and to achieve consistent results every time. I have divided my presentation into 3 parts. The upper face, the second part describes the mid and lower face, and the third one describes the vasculature of the face. Starting with the first part, the forehead area. As we lift up the skin in a cadaver, the most important structure in this area is the frontalis muscle, which runs from the medial to lateral side and bifurcates in a V-shaped manner, although not in this cadaveric dissection specimen. Here, important part to remember is when we inject neuromuscular injections, they should be 2 centimeters above the brow so that we do not cause brow ptosis after injecting them. The supratrochlear and supraorbital artery anastomose hair in this area and form the most important zone and can be considered as a danger zone because any retrograde flow in these can lead to blindness. In many of the surveys, it has been seen that glabular injections of the filler is the most common cause of blindness in patients. Next, deep to frontalis muscle, here lies the corrugator muscle, which spreads from the bone and attaches itself to the skin. It either can go vertically up or it can go horizontally in this direction. So whenever we want to inject into the corrugator muscle, ask the patient to animate and then inject. Inject deep into the corrugator muscle body and not superficial. The tail of the corrugator, however, when travels to the skin, lies superficially and we can inject superficially into the corrugator muscle there. Centrally, there is procerus muscle here. Pinch the muscle into your hand and inject the neuromuscular injection whenever you want to. Just take care of the retrograde flow here because the danger zone 1, as we saw, lies here. The supraorbital nerves and vessels lie here and run at the center of the forehead right here. Whenever we want to inject the neuromuscular injections or fillers, especially in cases of fillers, the injections should be multiple small bolus with less pressure in to and fro motion so that there is no risk of large boli and retrograde flow into the vessels. This is the fusion zone where the frontalis muscle fuses with the temporoparietal fascia. The next most important zone in the upper face is the temporal area. As we lift the skin, the temporal area is basically defined from the root of the helix to the lateral canthal area, inferiorly up to the fusion area superficially. When we lift the skin, we see the superficial temporoparietal fascia here. And below this superficial temporoparietal fascia lies the deep temporoparietal fascia. The danger zone 2 lies here right in front of the root of the helix. The superficial temporal artery becomes really superficial and lies 1 finger breadth above this brow area, and thus while injecting we should take care of injecting fillers in this area. The frontal branch of the temporal artery anastomoses with supraorbital and supratrochlear vessels here, and retrograde flow here can cause loss of vision. The middle temporal vein, as we can see here, is the most prominent structure here. It drains into jugular vein and emboli can travel retrogradely and can cause danger to life. This is also an important structure to remember here, the middle temporal vein. Inject superficially between skin, this fold, and superficial fascia, that is the superficial temporoparietal fascia, that is the safest zone in the temporal area to inject fillers. Coming on to the second part of the presentation, the midface. The important structure here is the facial nerve. Facial nerve lies deep into the root of the ear lobule here, and it travels up, gives two major branches here, the frontal nerve branch and the superficial temporal nerve branch, which lies above the zygomatic arch. They lie 1 finger breadth above the zygomatic arch here, above the lateral brow, and run in general with superficial temporal artery. So careful injections here again are required. Below the skin, in the midface, all the aesthetic contours are formed by the sustained fullness in the facial fat compartments. The superficial fat compartment, as we can see here, and when we lift these, the deep fat compartment, as we can see the deep fat compartment between the mimetic muscles of the face. The superficial lateral fat compartments are again divided into the temporal, lateral, cheek and neck area compartments. Whenever we want to inject fillers in this area, the malar area, it is important as we inject to take care of these mimetic muscles and inject 1 finger breadth below the inferior orbital rim and inject laterally and not medially, so that we do not first of all accentuate the nasolabial fold, and also the inferior orbital nerves and vessels lie here. So inject laterally and massage the filler medially. The branch of facial vein coming here, as we can see here in the malar area, in the superficial fat layers, so thus inject deep in this area. Coming to the perioral area, which is the next most important area in the midface, deep to the superficial medial fat compartment lie 4 major mimetic muscles around the perioral area: the zygomaticus major, the zygomaticus minor, levator anguli oris, and the deep anguli oris. So injections here, when we inject for crow's feet, if by mistake injected into the zygomaticus major muscle, can cause drooping of this angle of the mouth. That's why the crow's feet injections should be really superficial and carefully subdermal. This is the DAO, the deep anguli oris muscle, which lies here. Always whenever we have to inject here, the neuromuscular injections, we should inject laterally in the area of DAO and not in the area of DLI, which is a medial deep muscle which lies below the DAO. Injections into the DLI will cause droop of the lower lip. The important structure here is the masseter muscle again in the midface. Whenever we want to inject botulinum toxin into the masseter muscle for masseter hypertrophy or bruxism, as it is the most powerful muscle in the human body, it lies deep to the buccal fat pad. Ask the patient to clench the teeth and then get hold of the muscle, the lateral and the medial borders. Inject around 1 centimeter deep. As we can see, the needle goes in around 1 centimeter. That's when we can get the proper effect into the masseter muscle. So coming on to the vasculature part of the face, the facial artery starts from the neck. As it goes up, it becomes superficial. It lies one thumb breadth lateral to the commissure and takes a tortuous course and goes up and becomes really superficial here near the ala of the nose. Here in the superior lip, it gives a branch, the superior labial artery, which lies at the junction of wet and dry vermilion, deep to the orbicularis oris muscle, and the other branch, inferior labial artery, which lies deep to the DLI. Here, we can see this artery here. This again marks a danger zone as the facial artery really becomes superficial, close to the ala of the nose. Whenever we want to inject fillers here, fan the fillers or inject laterally and then massage them medially. And inject deep. Do not inject superficial in this area because of the facial artery running very superficial near the ala. Again, there is anastomosis, as we all know, near the angular vessels here. Any injections in the medial part of the face should not be in this area, and one should inject around 1 finger breadth below the inferior orbital rim and then massage the filler medially. Nose again is a very vascular structure here. All the vascularity of the nose is in the superficial plane. Whenever we want to inject fillers in the nose, since the facial artery branches into lateral nasal and arborizes with the columnar vessels here, and again near the radix, it anastomoses with the external nasal branch and lies superficially. So the most safe zone to inject fillers is the central third, as shown here. This central 1/3 of the nose is the safest zone and not the lower 1/3 and neither the upper 1/3 to inject fillers. And that too, when you move over this mass, we can see free movement of these structures. This is the zone where we need to inject the fillers. So that completes the vasculature of the face. Thank you for your kind attention, everyone.
Thanks to Shilpa for getting this done despite being unwell from Delhi. It's my pleasure to introduce to you Dr. Adit Gupta. Adit is a double fellowship certified oculofacial plastic surgeon, both from certified from India, from LVP, LV Prasad Eye Institute, my alma mater as well, and from Dr. Bob Goldberg. Adit is in practice in Mumbai. Over to Adit.
Hi, thanks, Debraj. Sorry, I'm still catching my breath, but just before we begin this talk, a show of hands as to how many people inject Botox already. Good, and how many want to? Everyone, so that's good. Since Shilpa has already made my job easy, she has already spoken about the anatomy in depth, I'm going to speak about the practical aspects of injection and how to choose your patients for botulinum toxin injection. So we all know, or we should rather know, that botulinum toxin was first invented by an ophthalmologist and not a dermatologist. It was an ophthalmologist-dermatology couple, Jean and Alistair Caruthers. So we should be proud of that fact that an ophthalmologist was the first one to use Botox. And even before they used it for spasms, another ophthalmologist used it for strabismus. So history of Botox dates back to ophthalmology, so we should regain that territory. Although we all know about the functional aspects of botulinum toxin injection, what we'll be focusing on are the cosmetic aspects. And for that, even before you injecting is not a very difficult job. Understanding the psyche of the patient or understanding what the patient wants gets the patient back to you when you perform these injections. Injections can be done even by your nurse. So more than injections, it's the evaluation of the patient that matters, and it should be a holistic evaluation. So it should not be just like, oh, I'm going to inject your eyes. You have to look at the whole face and maybe cover other areas than what your training taught you during your residency. So you should look at the skin quality, you should look at the fat pads, you should look at the contour of the bones, you should look at static as well as dynamic wrinkles, as you see in this nomogram which I've shown here. Once you have convinced your patient, you should also use your words with caution. You cannot be rough with these patients. You need to avoid certain words and use more words and create an ambience so that these patients like to visit your clinic, very similar to how you deal with a LASIK patient or a premium IOL patient. Now, this is a small video which shows how I evaluate my patients. So if you look at this gentleman, when I do a Botox injection, during the first consultation, I always ask the patient to show all possible range of movements on their face. So if we focus on the upper face, you see how the patient is asked to frown and raise their eyebrows so as to delineate all possible muscles which we need to work on. After that, I apply an EMLA cream or a prilocaine cream, which constitutes of prilocaine as well as lidocaine. This is a topical anesthetic solution which penetrates into the epidermis and the dermis and numbs the skin to a certain extent. This also acts like a placebo in many of the patients because you don't want to scare your patient, especially on the first visit. So this cream is left in place exactly at the points, or you can apply it like a sheet, following which an occlusive tape is used so that the cream penetrates into the dermis faster. So once this cream is applied, you can either spread it with a spatula or with your gloved fingers and then apply this occlusive tape which comes within the packaging of the cream. This occlusive tape usually helps in penetration, and so the wait time is less. So if you use this occlusive tape, you can inject the patient after 30 minutes. If you don't use it, you have to wait at least for 45 minutes to an hour before you inject. So these are small tips that help you in your practice to convince the patient. Now, focusing on the muscles that we'll be learning to inject on, the most common muscles for us are the orbicularis, the frontalis, and the eyebrow complex of muscles, which includes the corrugator, the depressor supercilii, and the procerus. Apart from that, obviously, you can expand your indications once you're more confident with these group of muscles. But as a rule, usually we try to avoid botulinum toxin injections in the mid-face area, except for certain specific indications or with very advanced training, because this is the most dangerous area for injecting botulinum toxin because it can cause very evident lip asymmetry. There are different molecules of Botox available in the market. Botulinum toxin by the Allergan was the first one to be introduced, following which a flurry of products came, like Nabota by Dr. Reddy's, Botogini, which is one of the cheapest available forms of Botox produced by an Indian company, and then there are different Korean brands available as well. I have personally used 2-3 of them, and I don't find very much difference in the efficacy. These came now because the patent which was with Allergan for 20 years has expired, so now a lot of companies are getting the botulinum toxin molecule. Now, for dilution, you should usually use 0.9% saline, which is non-preserved because it leads to lesser pain while injection. If you use distilled water by mistake, you can evidently make it out. The patient will scream and shout because it's very painful if you dilute botulinum toxin with distilled water. Concentration can be modified according to your need. I prefer a concentration of 4 units per 0.1 ml. Some people prefer 2.5. Some people who want to do a concentrated injection even dilute it to 10 units per 0.1 ml. It can be stored. Ideally, the company says you have to use it within the same day, but I have noticed that you can use it for up to 4 weeks if you store it in the lower compartment of your refrigerator. Some of my friends vouch that they've used it with same efficacy for 3 months as well. No special precaution is required, but you should not be too jerky while handling the molecule because it is very sensitive to touch and even temperature. This is a very good practice to follow in your clinics. This chart is easily available with the dealers that supply you Botox. So you should ask them for this chart so that you can chart exactly where you're giving the injection so that the repeatability, if the patient is happy with your first injection, you want to do it again and again at the same spot so that you don't have variations, because it's a very sensitive molecule. Even a 2 or 3 millimeters here and there can give different effects with the different group of muscles. So this chart is very good, which I follow. And then obviously I stress more upon consent nowadays because we usually tend to not take consents for minor procedures in our busy practice, like Chalazions, Botox. We should be taking consents because every injection which you do can have potential lethal complications as well. Now let's come to certain subgroup of muscles which we deal with. Let's go to our favorite area, which is also the best area to begin with for a beginner ophthalmologist, is the crow's feet area. Crow's feet is nothing but condensation of the orbicularis muscle, which is like a strap muscle. origin is at the medial canthus, rotates around the lateral canthus and goes back to the medial canthus. So there's no insertion at the lateral end, but it's like a sphincter muscle there. For starters, usually we begin with 10 to 12 units and go up to 30 units in bulky muscles. And you see they radiate towards the temple area. So sometimes if you have too much radiation, you can inject more points as seen here. As a rule of thumb, you should not go beneath the zygomatic arch. And while injecting, for a beginner, your hand should be within the orbital rim so that you don't inject too close to the eyeball. Sometimes diffusion into the lateral rectus can cause transient paralysis and diplopia. All these effects are reversible. So usually, as I said, around 12 to 30 units, 6 units each side. Start with 2 to 2 units at each spot, and then you can go higher depending on the effect that you get. This is a short video which shows injection of the lateral crow's feet area and the eyebrow complex. This is how the orbicularis origins and inserts. So you see it goes all around. So I use a 30 gauge needle. 29 gauge is good enough. Now 31 gauge is also available. And a 1 cc syringe because the resistance is less and easy to calibrate. Once you're experienced, you can inject with the needle pointing towards the eyeball or the orbital rim. Otherwise, you can go in a different direction away from the eyeball if you're not confident. As a beginner, you should keep your hand within the orbital rim, as I said, and then you inject at 3 points depending on the radiation. So this patient doesn't have too many radiations of the crow's feet. Sometimes a lot of people also add a little unit to the lower part of the lateral eyelid just to take care of the orbicularis roll. So this is the crosses marked in red are the area to be injected and the blue ones are to be avoided. Although with experience, you can go there as well with micro injections. Now coming to the eyebrow complex, mostly we have the medial depressors of the eyebrow and the lateral elevators, and the frontalis acts as an elevator and the orbicularis again as a depressor. But what we target is the medial depressors, that is the corrugator. Now corrugator is of varying lengths. If you see, it has a long tail in some people, and so you need to go a little more laterally, but you should not go beyond the mid pupillary line as it will cause a paradoxical depression. So this is how usually the procerus, the corrugator and the depressor supercilii are. So depressor supercilii is not seen very prominently in all cases, but especially in celebrities, if you see Shah Rukh Khan's eyebrow, he has a very prominent depressor supercilii. And then you target the lateral part of the eyebrow, which basically consists of the orbicularis oculi muscle. So you can go within the eyebrow hair as well, because this is the arch lift that mostly women want, and the tail of the eyebrow as well, which again gives a nice subtle elevation to the lateral part of the eyebrow. So you see, it's so comfortable for the patient. Hardly they wink, squeeze or anything if the injections are done in a good manner, and the needle should be replaced after every 6 or 7 pricks, because that is the sharpness of the needle stays up to that level. This is the last muscle which is being injected, the procerus, which you can hold within your thumb and fingers and then inject in the belly of the muscle, because it lies a little deeper than the orbicularis muscle. But not all crow's feet or not all wrinkles need Botox. So this old lady, if you see, she also has crow's feet. But these are mainly because if you look at the eyebrow position, the eyebrow is very depressed, right? If you see, this eyebrow is almost gone, this is the orbital rim, and the eyebrow has gone beneath the rim, because of which the skin gets redundant, and this is a pseudo crow's feet. Basically, these are static lines which cannot be. So if you inject Botox in this by mistake, she's not going to get a very good result. Now coming to forehead, which is also a very easy area to inject, but an easy area to go wrong as well, because if you give a frozen appearance, not many patients like it. You need to know the anatomy of the frontalis muscle very well. Frontalis can be bifid, it can be a unilateral sheet-like muscle, and you need, as a rule of thumb, you should avoid around a centimeter's area from above the eyebrow, because then the injection can get diffused in the eyebrow muscles and can cause adverse effects and depression of the eyebrow and a pseudotosis appearance. So this is the effect that you can get by injecting uniformly along these points. Depending on the diffusion capacity of the molecule, you need to space it out, and sometimes some people also like to do watercolor injections. But to begin with, in women, 10 to 15 units is a good dose to cover the frontalis, and in men it requires more dose, because men, the forehead is thicker and the muscle needs more injections. So 20 to 30 units is a good starting point for men for the forehead. There is a new technique which is also called as baby Botox or micro droplet Botox, where you dilute the Botox to a very low concentration and then inject very fine points all along the forehead. So you can keep injecting all around the forehead. As the concentration is less, you don't get that frozen appearance. This is very good for people who want to maintain some part of their animation, especially newsreaders, actors, models who want that. Now, we already spoke about the eyebrow and the complex, but these are general injection points which you can follow for the procerus, the depressor supercilii, and the corrugator muscles. Usually when I inject, I ask the patient to frown so that I can exactly delineate where to inject. And then this is the standard dosage followed for a young lady. 4 units in the procerus, 4 units in the belly of the corrugator, and around 2 to 3 units in the tail of the corrugator, which gives a nice subtle elevation as you see in the pre and the post pictures. Now, as I said, usually starting dose for the eyebrow complex is around 20 to 30 units in women and 30 to 40 units in men. This is the consensus guideline which has been published already, so I'm not creating it on myself. And then exaggerated glabellar lines, as you see in this lady, again, Botox is not going to do the job completely, but it is going to give you a softening effect, which then later on the static lines can be covered by injecting filler in this area, although it is a little dangerous. Botox can also be used to augment surgical results, as in this lady who underwent a blepharoplasty. You can see I have excised a little bit of skin from this area, and she gets a good decent result. We can see the tarsal platform now, but you see there is frown line still and the eyebrow is a little depressed. So you see with Botox at these particular points, you see you can lift the eyebrow and augment the results of a blepharoplasty. So these patients are happy, and you can give them a complimentary Botox after 2 weeks so that they keep coming back to you for Botox as well. It can also be used to adjust the eyelid fold. So if the eyelid fold is asymmetrical, which advanced training, you can see that this eyelid fold is higher. This eyelid fold after injection becomes a little lower. This is by injecting in the frontalis so that this eyebrow goes down, and contradictory, you lift the other part of the eyebrow. Now, although Botox is known to cause ptosis, we can also treat a very mild amount of ptosis with Botox. The mechanism here is that you inject in the orbicularis, which is a closing muscle of the eye, and the paradoxical muscle, that is the LPS, acts unopposed when you inject in the orbicularis. But you have to be in the pretarsal part of the orbicularis. You cannot be in the preseptal part, because otherwise it will cause ptosis again. So you inject exactly at that point, and then that causes maybe a 0.751 millimeter lift. Last but not the least, with eyebrow Botox, you have to be very careful because there can be imbalance as seen in this lady. And then you inject this POC point and treat the lady for any side effect. So lastly, I would like to conclude that look at the patient as a whole. Don't just treat the eyes. Go ahead and inject in the forehead, in the lower face, inject fillers, do everything that you can to look, make the patient look holistically a better person. And obviously the point driven here is that Botox is not to have similar expressions for all expressions on the face. So your injection techniques have to be very subtle so that patients can express and emote after injecting Botox. Thank you. Now, if there are any questions, we'll take them as last, because one speaker, Dr. Kasturi, will join us a little later. Now, we'll have Dr. Debraj join us. Everyone knows him. He's the director of the aesthetic clinics, runs a very successful cosmetic fellowship program, which gives you a good hands-on of injectables as well as the dermatological aspect of it. And he's now gone ahead beyond India and is now one of the early Indian members to be on the board of facial cosmetic surgery and the American Association of Facial Cosmetic Surgery. Debraj,
Thank you.
Please.
Thank you. Thanks, Adit. Thanks for your kind words. We've been doing this for a long time together. We've been friends. Adit and I come from the same institute. Our alma mater is LV Prasad Eye Institute. And then I started my career from ophthalmology, but my objective to get into ophthalmology was always to get into facial cosmetic surgery. So we've been doing this course for a while, and Dr. Kasturi stuck in another talk, so she'll come in. Now, why I'm saying this is because mine is on combination rejuvenation. You might find that you understand my talk a little bit better after Dr. Kasturi's talk, because she's going to be talking on the fillers. Why do we need to hear this? I mean, this was also the hall where people were talking of refractive surgery, and for people trained in ophthalmology and wanting to deal with vision, why should we treat this? Interestingly enough, when you look at the American Board of Facial Cosmetic Surgery, to which I belong and I'm the only Indian diplomate of the same, we realize that 1/3 of the diplomates of the American Board of Facial Cosmetic Surgery come from an ophthalmology background. So as a result of which, in the West at least, I know at least 10 oculofacial plastic surgeons in the US who are friends of mine, whose main surgery actually is rhinoplasty. It's neither blepharoplasty, it's neither ptosis, it's actually rhinoplasty. It's interesting because American Academy of Ophthalmology just recently published this review a few years ago, which said that by 2030, they expect in the US, the facial aesthetics to become one of the top earners in ophthalmology practices. These are not oculoplastics practices, these are ophthalmology practices. And that is something which is very interesting. Most importantly, when you start off with Botox and fillers, you don't really need machines, you just need consumables. And so it can be an easy way to bleed ophthalmologists into this type of practice. Like Adit said, let us not forget that ophthalmologists really started off with the use of botulinum toxin for facial aesthetics. And from that perspective, it's important to recreate and reclaim that territory. I'm faculty at all of these organizations for a long period of time, and so some of the products that I'm using, I'm on their board as well, so some of the products that I'm using have been provided by them. Now let's look at what we are trying to transform. I request no pictures of the patients, please, because patients' privacy needs to be protected. This is someone who is a police officer. She came in, she wanted to look more aesthetic. And she was very clear she didn't want any surgery. You, in your mind, can turn around and think what you would rate her on a scale of 0 to 10. On a scale of 0 to 10, with 0 being the least aesthetic and 10 being the most aesthetic, what would you rate her? And what are the reasons for that? But incremental changes on the face can make a massive difference. And small 1 millimeter changes can make on the face are literally like an inch everywhere else. Please don't record the patient slides. And when we move to this patient, 8 years later, you can see how the face is getting transformed. Ultimately, facial aesthetics is about please don't record patient slides. Please, I request you, please don't take patient photographs. So when you look at the way the patient has undergone a transformation, and this is all non-surgical transformation, you are aware what can be done. Now, this is also important when you look at under-eye problems, right? You look at the under-eye, you are an ophthalmologist, you see under-eye dark circles, you say, okay, let's go and do fillers. What you're not understanding is that is the sagging of the entire facial tissues which is causing the under-eye dark circles. Unless and until you have mechanisms to pull all the facial tissues upwards, whatever you do will be haphazard and not holistic in nature. We all understand, we all know this curve, we all understand that it's the S-shaped curve which is seen in youth, typically in younger women. And if you think of facial aging, what exactly is facial aging? It's all your facial tissues being pulled downwards by the action of gravity. So if all your facial tissues at any day or any moment of your life are moving downwards and medially, anti-aging therapy should be resulting in the upwards and lateral movement of the tissues. The same thing which is causing your under-eye dark circles or your under-eye tear trough deformity is also causing your nasolabial folds and is also causing the loss of definition in your chin and in your neck. So that's important to understand to treat people holistically. We all understand that as our testosterone levels go down, men enter their 40s and women enter their 40s as well. The estrogen levels tend to drop. These hormonal changes cause a redistribution of the facial fat. We also understand that there is also a bony change which is occurring. For instance, there is an absorption of the bone, plus the dentition is becoming smaller, plus the skull is rotating. All of this means that you have less and less support on the face. For lack of a better analogy, it's almost as if the face is falling, or the soft tissues of the face are falling off the hard tissue and they are beginning to hang downwards because of the lack of support. Or in a better way of knowing it, your soft tissue, which is really the bed sheet, is becoming more and more, because most of us are putting on weight as we age, but the bed, which is your bone, is becoming smaller. So that leads to a crumpling of tissue and an accumulation of tissue. If you understand this concept, you understand how fillers are used for facial contouring. Now, we wanted to see what aging on the Indian face looks like. And this was our study which was published in 2020. This was also rated by the Plastic and Reconstructive Surgery Journal, which is the flagship journal of the American Society of Plastic Surgeons, as the best paper from South Asia that particular year, 2020 and 2021. And just like when you do a slit lamp examination, what are you doing exactly on a slit lamp examination? You are trying to identify patterns which give you an understanding of how diseases are occurring. Similarly, aging is all about understanding patterns. Just look at these photographs, serial photographs, and see how the 20-year-old face morphs into the 30 and the 70-year-old face, and what happens at age 76. Look at this lady as she goes from her 20s, and when she reaches her 50s, see how her jawline starts to lose contour. At the same time, there is a tear trough deformity which is forming. The cervicomental angle is not as sharp as before, and you can see what I just explained. Everything's moving downwards. Mother gravity, ever so kind, is pulling everything downwards. Men have another variable as well. We are losing hair, and as you're losing hair and your forehead is becoming larger, that leads to certain other changes in the facial aging. And if you had to take this woman, why is this important? Because if she came into you at 49, you need to understand where she's coming from. And unless and until you understand the patterns of aging, how will you really decipher what will be the best anti-aging therapy for her? So all in all, what we really realized is that the upper third of the face ages relatively well. So in that sense, India is not really Botox country in that sense, because you're not really having a lot of wrinkles on your forehead, etc., especially because we have melanin in our skin, which tends to protect our skin from aging from the ultraviolet rays of the sun. So you don't see, even in a 60-year-old Indian man, wrinkles on the back of the neck. You may not see it, which you will see in a Caucasian, blue-eyed, white-skinned person. It is really the mid-face and the lower face and the neck which is aging in Indians, and it is basically this which needs to be redressed. So if you don't redress this, anything you do in the under eye areas is going to be superfluous and not going to handle the entire face holistically. We all understand that there are nasolabial folds, there are these laugh lines which develop, and we already explained how they happen. And if there are very simple laugh lines like these ones, this is a very superficial laugh line. This literally we could teach someone in the audience to do in the space of literally 5 minutes, right? It's a small filler procedure which takes about 5 minutes, done in the precincts of your office. You are taking a low G prime filler, layering the line, and the line becomes almost absent. Hyaluronic acid being the way it is, it will also absorb some water, so this line will completely disappear in the space of 2 weeks or so, depending on what sort of osmolarity of the thing you're using. Now let's look at this particular patient of ours. This patient came in because she wanted a ptosis surgery. Ptosis surgery, why? Because the patient thought that one eye looks very different from the other eye. If you also look carefully, you can see that there's a telltale sign. The right eyebrow is higher than the left eyebrow. There is also an inferior scleral show which is there on the right side, which is not there on the left side. The moment the person smiles, please no patient photographs. The moment the patient smiles, it becomes very clear that the left eye is actually becoming smaller. When you pay attention to the fact that she is a model coordinator who also models, and she's always under the gaze of the high definition camera, you can understand why this is distressing her so much. But there is no problem with the upper eyelid. She has gone and she has been suggested a ptosis surgery. There is no ptosis. If you look at MRD1, it's almost the same. It's actually the difference or the orbital dystopia and the position of the lower eyelids which is making this problem. So why do you want to do surgery? And what we did, or what we are doing continuously for this patient who's been under follow-up for 8 to 10 years now, is we did 2 units of Botox in what we call the hypertrophic orbicularis oculi to flatten that out, that roll below the eyes. You must have all known patients who, when they smile, their eyes become so small, right? Either their teeth are seen or their eyes are seen. And to make both seen, sometimes the Botox in the pretarsal area and the lower eyelid makes a big difference. And then just a little bit of fillers, which is done with the bevel down, a low G prime filler, which is done in the tear trough deformity, and the objective of this is to fill up the trough. Moment you do this, this is how she looks. The moment she smiles now, you can see how symmetrical she is. So she's literally gone from there to there. The fillers in the under eye area, are going to last for approximately 18 months or so. The Botox is hardly 2 units of Botox, costs hardly 700 rupees to the patient, and it's going to last about 3 months or so. What I'm trying to say is, if you turn around and think that surgery is the only option, if the only thing in your tool bag is going to be be a hammer, everyone's going to look like a nail. So it's important to have different tool kits available. For instance, look at this lady. She's 36. She's got this asymmetrical face. She's got this under eye bag specifically on one side, right? She doesn't want to undergo surgery. You can say blepharoplasty, but she doesn't want a blepharoplasty at all. What would you do? We did a filler. So you can either remove the fat bag or you can camouflage the fat bag. So that's an important technique to know. We've done the filler. This is immediately post the filler. You can see the injection marks can be seen still. 1 week later, look at how the lid cheek junction changes. Look at how youthful her face looks. The rest of the asymmetry is there because she didn't want to address it. But you can see that that entire orbit on that side, the face on that side, the eyebrow on that side is asymmetrical. That is what you will find. And that's why it's important to be able to treat it in multiple ways. We also use lasers a lot, and two of the lasers which are our workhorse lasers, which we use literally in every patient of our surgery or otherwise, are the fractional CO2 laser and the Q-switched Nd:YAG laser. The Q-switched Nd:YAG laser works really well in pigmentation, especially when you've done and addressed the volume loss by doing a fat grafting or doing fillers. This does well in removing the dermal pigmentation. You can also use peels. You can use Cosmelan. There are so many peels available which can do it. And fractional CO2 is for those thin lines which you see, which is used for rejuvenation. Now let's look at some of these patients, right? Look at a combination treatment of trichloroacetic acid peels, lactic acid peels, and some Q-switched Nd:YAG laser, and the difference that that creates. Look at this patient who otherwise would have been a surgical patient, but we treated with fillers and some CO2 laser on the skin side to tighten the skin in order to make these disappear, right? Everyone will not want surgery, especially in young patients. Even if you've repositioned the fat, I have patients 10 years ago we did blepharoplasty on. They come back sometimes with fat bags again. How many times can you do a surgery? Those are also considerations that need to be considered, right? And doesn't matter how good a surgeon we are. Please don't take patient photographs. Excuse me, sir, please don't take patient photographs. So if you look at this particular patient, you can see that there is under eye hollowing. There are these thin lines which are there. There's also pigmentation. People will come with multiple problems. You can't just treat one aspect of it and take it away. There was this interesting study which was published by L.V. Prasad Eye Institute, which showed clearly that when ophthalmologists do LASIK surgery, people sometimes end up being even more unhappy. Unhappy why? Their vision has cleared. You remove the glasses. Now the under eye dark circles can be seen. So using all of these things are important because ultimately patients deserve to be treated holistically. That's a patient of ours, 46 years old. She didn't come in because she wanted to look young. She didn't come in because she wanted to look pretty. She came in because she wanted to look rested. She said, I look tired, I want to look rested. Is there something you can do for me? People think I'm lacking in energy. We did a little bit of Botox, a little bit of fillers. Adit talked about the Botox, Dr. Kasturi will talk about the fillers. But essentially, she went from here to here in the space of like 2 weeks, right? After the Botox and the fillers have settled, this interestingly is a patient from 2006. That was the time we didn't even have the high grade or the high G prime fillers we do today. But even with the low G prime fillers and the Botox, everyone uses the same guns. People don't get the same results with the guns. So that's important to understand technology well. Now, another patient, different patient, very heavy face, Middle Eastern patient from Oman. She's got this mountain above the valley. Unless and until you can get the mountain to move upwards, you are not going to be able to just use fillers in her. So utilizing high G prime fillers properly on the lateral part of the face in order to increase the structural support and allow the face to be pulled laterally from where it's coming or hanging down, and then using low G prime fillers in the valleys will give you good results, allowing the person to look rested. The reason some people or some celebrities on television look funny with fillers is not the fault of fillers. It's just injectors who don't know how to inject. You don't know how to do a certain thing. For instance, a LASIK machine that you guys use is useless in my hands, right? So it's knowing how to use things and using them well, right? Face thread lift is something we do regularly. And this is an office procedure where we insert threads into the face. These are like barbed wires which are completely absorbable. simple, and it's a non-surgical facelift which gets done, inserted into the face, uplifts your face, makes the face look tighter, makes the face look better. These threads will disappear in approximately about 9 months or so, but the results last for about 2 years, right? So if you have a heavy face like this, using threads becomes important. Using threads, you'll be able to shift the facial tissues laterally from where they came, and then you can layer the valleys, etc., leading to these sort of results. That's also a patient who's undergone carbon dioxide laser resurfacing. That's why she has those scabs on her skin, which has been done. Look at her face. She looks angry, right? Or she looks very sheer. Just changing the metrics and using fillers, threads, Botox, etc. could give you a nice, more pleasant looking face, right? Ultimately, perceptions are reality. That's also the reason when you give a gift, you want to give it in a good wrapper. That's what our faces are. That's our present to the world, if you will. There are other devices, etc. There's just so much in facial aesthetics. I don't think I can do justice to it in 15 minutes time, but things like the Altera, which are non-surgical facelift devices, which basically are what technology that is being transforming the face. So essentially, these are devices which do a facelift, right? You literally, it's like a probe which is going on the face, releasing high intensity focused ultrasound energy on the face, allowing the facial tissues to be lifted up, causing the under eyes and every other part of the face to look better, right? That's our paper, which was published on the Altera in the PRS. And this was the first paper from India. Look at this lady and look at how her jowls and her neckline look so much more defined. That's an almost surgery-like result, but done without surgery, done with the Altera. Another patient of ours with the Altera. Certain other machines as well, too many machines, but all in all, technology's got to the stage where surgery or our facelifts have reduced by almost 60-70%. We don't need to do surgical facelift. Just like in ophthalmology, aesthetics is a very technology-dependent branch, and depending on the technology that you can use, you can do a lot. Some people will need surgery, so we do the mid-face lift very regularly, and that's a small 45-minute procedure done from the supraciliary sulcus inside the mouth, and then you take the sutures up behind, and there's an incision which is behind the hairline. So essentially you're lifting up the cheek. One incision is inside the mouth, one is behind the hairline, and you can literally see how the cheek gets lifted up. And that's something that we do regularly to do a mid-face lift. Let's look at a certain patient who's undergone the mid-face lift. That's a 66-year-old lady who came into us from Utah in Salt Lake City, and she underwent a blepharoplasty and a mid-face lift and carbon dioxide laser. She's still 66, but maybe her soul, which was younger, now matches the face. Another person who came in, a 70-year-old, you can see there's dermatochalasis, needs a upper and a lower eyelid blepharoplasty, but just doing a upper and a lower eyelid blepharoplasty is not going to cut it. You will have to treat the rest of the face as well, because if you don't do that, then you will not be able to do justice in giving the patient a holistic look. One more of our mid-face lifts. This patient was actually operated just 3 weeks ago. We've been maintaining her. She's 44. We've been maintaining her on fillers, etc. for a long period of time. But as she's aged, you can see that there is a little bit of a volume loss, etc., which has occurred here. And then we decided it was the right time to do a small blepharoplasty, upper eyelid blepharoplasty, do some facelift. This is 1 week post the surgery. This is just before she left for the US. You can see how the facial shape has changed, how it used to be much heavier, the lower face, and that has all got lifted up and is becoming much more oval, doing well now. Facial liposuction is also something that we do very regularly. It's reducing, of course, with the amount of deoxycholic acid we've started to use now in the lower neck and the face areas and in the jowl, which is a lipolytic solution. But essentially what you're doing is taking tissue from those areas which are very heavy and repositioning them to the upper part of the face from where they came. So imagine a lady like this, 46, right? But see the difference that the change in the facial shape makes, because you can literally take the facial tissues from the lower part of the face and transposition it to the upper part and make a difference. One of my last patients now, 48-year-old patient who came in from Lebanon. I won't tell you the reasons why, but she came in and said, I look aged, I want my dignity back. And that's how we gave her dignity back. Giving her a number of non-surgical treatments, making sure that the facial shape changes, and understanding the tenets of aging so that we can then go ahead and retransform or redrape the face and do it in a non-surgical manner, in a predictable manner, makes all the difference. Few other things before I move on. Everything doesn't require surgery. These were results which until 15 years ago we had to rely on shaving the angle of the jaw to produce, but this is something which can now be done even with Botox. This is a Botox in masseter hypertrophy which we've utilized. These are serial pictures which show the change in the facial shape, and our paper on this, which was actually published in PRS, showed that if you do 4 sessions of these, the results can last up to 4 years or more. Rhinoplasty, surgical rhinoplasty is very common in our practices, but everyone doesn't need a surgery. You can actually do fillers. And I will just go ahead and show you one patient to showcase what differences we can create. For instance, this is a patient who's an actress. She is from Marathi cinemas. And she came in, she didn't want a surgical rhinoplasty. You see, she's got a nice nose. But the moment she smiles, you can see how that nose drops down. Using fillers, using threads, etc., you can transform the angle also. This is something which if we were doing a surgical rhinoplasty, we would need a columella strut graft. And we've been able to achieve it without a strut because of the way we use high G' fillers, etc. now. I'll bring my talk to an end now. All in all, facial aesthetics is a rapidly expanding branch. A 1.5 hour vast session can't do justice to this, but obviously there are ways and means by which you can learn this. We have dedicated our lives and our careers to this, and in case you think this is useful, please come down and we'll be happy to teach you some of these techniques and take it from there. Over to Dr. Kasturi, for whose talk we've been waiting till now.
Excuse me. Thank you, Dr. Debraj, for having me in your course. So I'll go brief. I think we have got just 10 minutes.
No, we've got time till 3. We started 15 minutes late. You've got 20 minutes, ma'am.
You can directly HDMI. So I'll be talking about dermal fillers, but since I could see that we are all ophthalmologists, so I'll stick mostly to the periocular indication of dermal fillers. So is it coming? Dr. Debraj wanted me to speak more on the facial rejuvenation, but rest I will touch in very brief, but my main highlight will be for the periocular rejuvenation. So when we looked at a global approach to facial rejuvenation, we see that when people are young, at the age of 20 to 30s, it is basically to enhance the features. So at 40 to 50s, it is basically maintenance, and when people grow old, at 60 to 70s, it is basically restoration. So whether it is for enhancement or maintenance or restoration, the main way of managing all the situation is by injection dermal filler. And when we say the dermal filler, we have both the natural and also the synthetic types. And what we prefer, most of us, whether Dr. Adit or Dr. Debraj or myself, we prefer the natural sources, that is basically the hyaluronic acid fillers. So being an ophthalmologist, I like to concentrate more on the periocular region, but also the structures which is near the eye, like the nose, a little bit of the lips, if you want, and also we can touch a little bit of the eyebrows. So what are the periocular indication of dermal filler? It is number 1, to bridge the hollows. And what are the hollows? The tear trough is a hollow, the sunken superior sulcus is a hollow, and the deflated eyebrow or the deflated orbit itself is a hollow. So the best way of rejuvenating all these hollows are by dermal fillers. And when I say the most common hollow that we see around the eye is a tear trough, and this tear trough is basically a separation of the orbital part of the orbicularis from the palpable part of the orbicularis. So you should know what is a true tear trough. When you look to the whole of the orbital part of the orbicularis, when we look to the whole anatomy of the orbicularis, it has got multiple parts, one is the palpable and one is the orbital. So when there's a split between these two parts, we call it the prominent tear trough. And then you need to separate this true tear trough from a false tear trough, where many people think this nasojugal fold, which is basically a fold between the whole of the orbicularis, that is the orbital part of the orbicularis, from the quadrate group of muscle, that is the levator labii superior eleginaceae. So many people think that this is the tear trough. So you should try to differentiate between the two, and then accordingly you place your filler. Okay, so this injection dermal filler can do really wonders around the eye. First, definitely, as I have already mentioned, the correction of the tear trough. And secondly, in Indian scenario, we get the periocular hyperpigmentation very common. Multiple reasons are to it, and one of the reason being the shadowing. So this all not only corrects the tear trough, but also corrects the hyperpigmentation. Like this is a lady that you can see so much of hyperpigmentation with a prominent tear trough, and this we could overcome by giving an injection dermal filler. So this is a point which we call the cheek point or the main point for the main modulus of injection, and then once you touch the main of the cheek point, you need to inject directly into the tear trough. This injection in the tear trough can be done with a needle or with a cannula, and I'll go into details in some of my later slides. So this is how we inject, but always remember that this tear trough region is not very simple. You have a very major blood vessels. You should be very careful so that you don't end up with any vascular complication. And this is how she looks after the procedure. And when you look her nicely, see, look the amount of the pigmentation and amount of the depression. And this is how immediately after the procedure, how she looks much prettier and much beautiful following the surgery. So tear trough dermal filler number 1, it corrects the tear trough, it corrects the pigmentation, and third thing, it conceals the fat pad, especially in the young people. Like if you look to the small fat pad, you can see there's a small fat pad here, and just after the procedure, you can see that the fat pad has much decreased. There's another lady with a very small prominent fat pad, along with a prominent tear trough. This is much being reduced after the surgical procedure. So what I usually prefer is that I use a cannula when doing the procedure, but there are ways where you can use a needle also to do the same procedure. So I usually mark the infraorbital rim. Another line I keep approximately 0.5 to 1 millimeter below, and I try to stay within this zone. So give a very small amount of microelucate, very small amount of injection, and it's always advisable to do a undercorrection than to do a overcorrection. So you go along the whole of the infraorbital rim, and you try to fill it. You have to try to fill the tip of the cannula. Advantage, the tip of the cannula being blunt, so chances of vascular complication is much less. So these are the patients, you can see this is just a few, I think the day 1. Can you see how beautifully the fat pad got concealed before and after the surgical procedure? So the results are so immediate. Like this is even you can see the entry point of the cannula, and this is a fat pad that got concealed after the procedure. So these are some of the patients that you will see before and after the dermal filler, where very beautifully you can correct the tear trough, you can correct the shadowing effect, and also you can correct the conceals the fat pad. Here I would like to show how to do an injection with a needle. So in the same way you mark the infraorbital rim, and then the most important, when you do a needle injection, you have to aspirate, and the time of aspiration follows varies from 8 seconds to 39 seconds, but I usually wait for approximately 12 seconds before I inject the dermal filler. So very slow amount, you can see a very slow amount needs to be injected, and you will see the results immediately on the table. Like this is how you mark the infraorbital rim, and this is how I'm marking where the anatomical landmark of the infraorbital blood vessel. This is a main C point that we say. This is a point where all the ligaments get attached to it, where many of the plastic surgeons calls it the G point. And then you mark in the 3 major points, like centrally you can give 0.2, then medially 0.1, and laterally 0.2. It is not necessary that you follow what is the textbook says, but you should follow what the patient wants. Always do an undercorrection. You should customize the amount of feeling. And the lady, you can see the right side is being injected. Sorry, my voice is totally gone. And you'll see on the table, you'll see the changes. See, this is the right side that is injected. The fat bag is not there. The left side needs to be injected, and you can see the fat bag is much prominent. So the results are very immediate, and you'll see a definitely change. And the patient looks much rejuvenated following the procedure. And not only that, the correction of this negative vector into a positive vector following the injection procedure. Another indication of dermal filler is a correction of the A-frame deformity. What is this A-frame deformity we see in the eyelid? It is a prominent superior sulcus. That is, the superior sulcus becomes much sunken. So I feel the best way of managing this is with dermal filler. There are different routes to it. Many people go for pre-periosteal. I like to go pre-septal because the space is more and the vessels are much less. So chances of vascular complication is much less. This is what you see, how slowly I am injecting, and you don't go for a very high concentration dermal filler, and you really need to massage very well when you do the procedure. And this is a patient, she looks immediately on the table. This is, see how the superior sulcus, and this is after the procedure, and this is how she looks before and after the procedure, and this is the beauty. You can see the whole of the superior sulcus, and it looks so good tissue. If you don't mind, don't take much of these videos and the patient's picture. And you can see so beautiful correction of the superior sulcus. So this, and I would like to show one lady. You can see this A-frame deformity, which is very, very common, and this should not be ignored because this is something very important which needs to be done. It needs to be treated when a patient comes to you for a cosmetic rejuvenation. And being ophthalmologist, it becomes much easier for us. And a very simple way is a pre-septal, which is very safe, but you need to mold the product very well. You wait for some time, give a very nice massage, and these are very, what is not a very concentrated hyaluronic acid, so it can be molded very well. And this is how she changes on the table. This is just before the dermal filler injection. This is the next picture you are seeing. This is just after the injection, and then you see the beautiful result. This is approximately a week after the injection procedure. So you can see the whole of the superior sulcus got camouflage with a dermal filler. So these are some of the pre and the post-operative patient. This is how she looks, and this is after the injection of the dermal filler. So many times what happened when we all started with the blepharoplasty procedures, we were very aggressive. What Dr. Debraj has already mentioned, we try to excise as much of fat as possible, and we land the patient, young girl with so much of sagginess of the skin. You can see so much of loss of tissue. And this has been done because of the excessive removal of the fat during the procedure. So how do you correct this type of problem? This can be also corrected by augmenting the same region with a dermal filler. And this is how you can see the same lady where I had only done the blepharoplasty when I was, many years back, and I landed with so much of, tissue loss. And this you can done augmentation with a dermal filler. The same cannula is being used, and now you can see the change before and after the procedure. And when the patient animates, you see the skin looks much better following the procedure. Other periocular indication can be many patients, they are reluctant to take botulinum toxin type A because they feel that it's a toxin. So it works very good for the crow's feet, and you can usually go just above the orbicularis muscle and inject the product. And this is a patient where the scar has been revised following the injection of the dermal filler. My voice is gone. A brow lift is also a procedure where you can use the dermal filler, especially in those type of deflated brow. It can be done with needle and it can be done with a cannula. I prefer a cannula because I feel that a cannula is safer, and this, she's so young, but she has got so much of deflation around the eyebrow region, and being a very prominent personality, so I've used a cannula to correct this deflated eyebrow. And then this is how she came, and this is on the table. You can see even the shape looks so beautiful following the dermal procedure. This is something challenging that I like to show. Sometimes patient comes to you with anophthalmia. So these are very difficult cases because these patients, they want some amount of correction of anophthalmia, and this is a pure functional indication of dermal filler. But please don't try as a beginner, because she has got 6/6 vision and she wants a non-surgical way of correcting her anophthalmia. So what I have done, I have used a dermal filler, but mind you, I am using a cannula. Just give a first entry with a bigger size needle, aspirate very well, and when you inject, you have to monitor the pupil. Do I still have time, Debraj? And then you can see I'm monitoring the pupil in every step. This is look to the right. This is just after the procedure. And you can see the correction of inophthalmos. This is post-operatively. And I've been following her for more than 3 years now. And she is not requiring any further augmentation. This is how she came to us. And we looked to her superior sulcus deformity. And it is much better following the injection dermal filler. But this should be done as a very advanced procedure. And please not for the beginner. So before I like to end, I'd like to mention a very important point, that is a CK1 point. This is a cheek point which is very important, because on this point, all the main ligaments are being attached, whether it is zygomatic ligament or orbitomallear ligament, or you have the STL. So these are the main ligaments which are all attached to this point, and this is a G point where you need to touch this G point, and which with a small single touch, it can correct so many things. It can correct your tear trough, it can also lift your eyebrow, and also it can correct the nasolabial fold. Like this is some of the patient where only a mid-face filler has been done, mainly concentrating on the CK points, and you can see without touching the other point, you can see a very beautiful correction, a very good lifting of the face or the ovalization of the face. And as Debraj has already mentioned about the liquid rhinoplasty, this has become a very common indication, especially those patients who have a deformed nose because of trauma, or as a cosmetic indication, and a very good way of lifting the tip, which Debraj has already shown so beautifully. So with this, I'd like to mention that always remember that dermal filler are not medicine. Like in medicine, we like antibiotic, 500 milligram 3 times per day, we can say. But in dermal filler, we don't know whether what is the amount of volume. It depends upon your experience, so you need to customize. So the main complication may be the volume is too much, or it can be too less. The depth can be too superficial or too less. Like this is one of my patient initial days where you can see you can see the lumps out there. But I have given hyaluronidase and immediately it got corrected. So these are some of the complications, but one major complication is a vascular complication. So you should be very careful. But one thing we are very lucky, because we have both the true anastomosis and the choke anastomosis on the face. So if the product enters into choke anastomosis, then it leads to localized vascular complication. But if it enters into the true blood vessel, then definitely you might end up with a vascular complication. So please aspirate before you do such procedures. So you should have a filler crash kit, the most important being the steroids and hyaluronidase, etc. And you should, if you have any complication, immediately you go for injection hyaluronidase. Like this lady, she had developed a nodule during the COVID era. At least she had developed 6 months after the dermal filler. When I injected her hyaluronidase, this has all that led her to some reaction, but now she is much better. So you may have multiple complications, but you should be having all your armamentarium ready with you, so that even there is complication, you should be able to manage it. With this, I conclude. Thank you very much for having me with you all.
We declare this session closed. Thank you.